Dear friends, good afternoon or good morning or good evening, according where you are located in the world. Today we have our webinar is dedicated to a paper very recently appeared on the issue of GREM. I remind you, GREM is Gynecological and Reproductive Endocrinology and Metabolism, is our open access journal of the International Society of Gynecological Endocrinology. And we choose normally inside to the new appearance, always an interesting article where we ask the author to discuss and to present the paper and also to present us the basic of the investigation, the reason of this investigation and what this can have as impact on our daily practice. Today is with us Alessandro Genazzani, which is the chief of the section of gynecological endocrinology in the Department of OBGYN at University of Modena in Italy. He is degreed in endocrinology and in OBGYN. He's a PhD on human psychobiology in '94, associate professor at the Department of OBGYN at University of Modena. He's author and co-author of more than 190 original papers in international peer-reviewed journal, and is editor or co-editor of 14 scientific volumes. He is serving in the editorial board member of reputed international journal and reviewer of more than 15 journals. At present, he is member of several scientific societies, such as the Endocrine Society, the IMS, the Gynecological Endocrinology, the Italian Association of Gynecological Endocrinology, and is the president and scientific director of the Italian Association of Gynecological Endocrinology and director of HIGE School and editor-in-chief of the HIGE Bulletin. And his research area are neuroendocrine, endocrine control of reproduction, hypothalamic dysfunction, polycystic ovary, obesity, hyperinsulinism, peri and postmenopausal disturbances. Too many. But and today he will speak about his very recent paper on hepatic insulin extraction index in overweight, obese, polycystic ovary syndrome patients with or without familial diabetes. Please, Alessandro, you have the microphone.
Thank you to all. Thank you, Andrea, for this wonderful and very kind presentation. And well, the starting of the story is that when dealing with polycystic ovary, we not always have a clear idea of what really we might expect when trying to disclose the reasons for all the situations that PCO patients might show. And we know very well, this is the title of the paper that was on GREM in the late issue. And we know very well that usually when defining PCOS, we need to have 2 over the 3 classic criteria of the Rotterdam Consensus Conference. And we know that the combination of these 3 made 4 possible phenotypes. But all of these is not including the new issue of PCOS, which is the metabolic issue. The metabolic issue, which is represented by the insulin resistance, the reduction of the insulin sensitivity, and a lot of issues related to the dysmetabolic situation that these patients very often show, which is the risk of diabetes, or at least to have diabetes not only in a short time, but also within 10 years from the beginning of the problem of PCOS and of insulin resistance. So in our department, I have started thinking a little bit more attentively why these patients should have this such higher risk of having this metabolism and mainly a change in insulin sensitivity. So what we know that clearly PCOS is characterized with a high incidence of overweight or obesity. But mainly there is an issue which is probably not yet too much explored, which is the fact that at least up to 50%, even more in some ethniae, the presence of diabetic relatives, which means father or mother, or maybe grandfather or grandmother, show diabetes. And the fact that quite often these patients have very high level, or at least a level of insulin in baseline conditions, in the fasting condition in the morning, higher than 12 microunits milliliter. Well, all these facts have been in part, but not so attentively, studied all over these last 10, 15 years. But we know very well that PCOS have a destiny. The destiny is that they might show the evolution to one or more of these situations: metabolic syndrome, hyperinsulinemia with insulin resistance, elevation of transaminase from the liver, and hepatic steatosis, which means non-alcoholic fat liver disease, and over these, dyslipidemia and the risk of diabetes. So the real problem, we decided to face this and to understand a little bit. So we took a group of patients that we have started to follow for the PCOS and selected them over a great large number just to have more homogeneity. And we kept 53 patients, and all these were very homogeneous. They were overweight, obese, with body mass index above 30. And we subdivided them according to the levels of the insulin in baseline conditions, and mainly to the presence or absence of someone diabetic in the family. All these patients were analyzed for the baseline conditions from the hormonal and metabolic profiles, and all of them underwent to the oral glucose tolerance test. But we made a little bit of difference this time. We not only assayed glycemia and insulinemia, we assayed also C-peptide, which is, and we discussed a little bit on this, related to the amount of insulin circulating in the blood, since you know very well that the C-peptide and insulin are released together from the pancreas. Well, we made some definitions that have been already stated in our papers in the previous years, since we recognize the presence of a hyperinsulinemic response to the oral glucose test when we have a response above 50 microunits per milliliter within 90 minutes from the glucose load. And we, as I told you, have checked how many patients of these might have diabetes in the family, and how many of these have, in baseline conditions in the morning, the presence of insulinemia above 12 microunits per milliliter. So the first thing that we made was just to redistribute these patients, subdividing them according to the presence or absence of familial diabetes, and observing how many of them were showing the presence of an hyper response to the oral glucose test, and how many of them might have the presence of high level in baseline conditions of insulin. Well, we discovered that the presence of familial diabetes was more or less in 31 of the patients. So almost 60% of the patients we studied were with someone in the family with diabetes. But most of them, up to 55% of them, showed in baseline conditions high level of insulinemia. And this was significant. So this means that the presence of diabetes in the family was, for some degree, driving towards high level of insulin in the fasting conditions in the morning. When we subdivided these patients just according to the presence of diabetes, we demonstrated, and this is the second time that we did this, that whenever there is diabetic relatives in the family, we have a higher level of transaminase from the liver. And the fact that we have the presence of higher level of transaminase doesn't mean that we have hepatitis or something like that. These were just above the levels shown and demonstrated in the other group of patients with no diabetic in the family, and they were in any case within the normal range, but they were higher than the expected, and exactly in the group of diabetic relatives. So what is the story that we are trying to disclose here? Well, I want to show you something that we probably, I studied this when I was studying physiology, when I was a student in the School of Medicine in Firenze, and later when I was doing the postdoc school in endocrinology, but it's a refreshing. The refreshing is that pancreas is the one that is in charge for the production of insulin, and this organ produces from the Langerhans cells insulin, just producing proinsulin, which is cleaved into molecules, insulin and C-peptide. So there is a ratio between insulin and C-peptide of 1, since there is an equimolar distribution of these two compounds. The blood from the pancreas passes through the liver, and the liver is in charge of cleaning a lot of substances in the blood, but mainly also cleaning insulin. So we have up to 50% of the clearance, metabolic clearance of insulin performed by liver. So it is clear that since C-peptide is just eliminated as it is in other ways, and no liver degradation is performed, up to 5% in some papers has been described, the ratio between insulin and C-peptide is no more 1, but is 0.5, 0.6. So this means that the expected ratio between the two is a relevant index, since it gives you clear idea on what the liver is doing. Since if insulin is not degraded, the ratio is much closer to 1 in comparison to the regularity, which should be much closer to 0.5. So why this is important? It's important since we have to discuss later on how in PCOS patients the secretion and the release of insulin is performed. We have to know that in normal conditions, whenever you have the glucose load, you release in a couple of minutes, in 5 minutes, a lot of insulin, which is stored in the Golgi apparatus, in the granules of the Golgi apparatus, and it has been loaded, all these granules, with insulin ready to be released when you have the glucose load. And you see here the black dots. The increase of insulin is much higher than the very low level of C-peptide here. This is the so-called fast insulin release. The fast insulin release stopped when all the amount of the ready amount of insulin has been secreted in the blood. And in that moment, you have little by little the rising of the slow release of insulin, which is started to be produced just to follow the control of the glycemia after that you have done the load of glucose. And you see here that the insulin is rising little by little, but it has the parallel rising of C-peptide. So if we perform the insulin to C-peptide ratio, we might have such kind of schematic representation. Before the glucose load, you have such kind of ratio. Then you have the fast release of the already stored and ready to be used insulin with no C-peptide, and this is a high ratio. After that, insulin is exhausted, the fast release of insulin is stopped, and then the ratio is going down since it started to have the slow release of insulin. And again, the ratio comes again to a normal constant value. So according to this, we decided to follow and to calculate the hepatic insulin extraction, so the ratio between insulin and C-peptide, in the two groups of patients, those with familial diabetes and in those with no familial diabetes. And we had such kind of very nice diagram. Whenever you have the increase of insulin extraction index, well, the going down, so the stop of the release of the already stored insulin, was followed by a decay only in the patients who have no diabetes in the family, while the other group, the patients with the presence of someone with diabetes in the family, in the father, mother, or grandfathers and grandmother, didn't show such decay. And you see here that the going down was significant between after 30 towards the 60 minutes of the glucose load in these patients. So this clearly gives the idea that there is something probably going on differently in these two groups of patients. So we tried to disclose this, just checking also what was going on when, on the other side, we would eventually have tried to see the differences according to the level of insulin in the morning, which is above or below the 12 microunits per milliliter. And we found that whenever you have such kind of levels of insulin above this limit, you have a higher level of glucose, of insulin, of cholesterol, of HDL, LDL, and mainly you have also higher level of HOMA index, and also, even though these are all almost obese patients, the BMI is higher. So everything is different, with the only distinction in transaminase. These were not difference between the two groups. So we decided to perform, according to this, the computation and the graphic representation of the hepatic insulin index in the cases of insulin below or above 12. Well, you see here, these are all the patients. Whenever you have the level below the limit, well, the graph is very nice, quite normal. You see the distinction of the going down of the HEA index, the hepatic insulin extraction index, but such kind of going down is not present when the level of insulin in baseline condition are higher than 12. And look here, when you have the presence of diabetes in the family, the shape of the curve is completely different. We have the loss of such kind of decay. You have a sort of panettone-like shape, both when the insulin level is below 12 or higher than 12 microunits milliliter. And when no familial diabetes is observed, you see here that in both situations, below 12 or above 12, you have a similar shape with a significant decay from the higher point of the HEE index and the following point. So this gives clear idea that there are some differences here in these patients, and such kind of differences might be related to something occurring in these two groups. So we decided to again reassemble the groups of the patients, and we tried to understand if there was any kind of difference, yes, related to the baseline level of insulin in the morning, but is it related to the presence or absence of familial diabetes? Well, we observed that the combination of the presence of higher level of insulin in the morning and familial diabetes showed the most impaired hormonal profile in these patients. The higher level of LH and obviously of the LH to FSH ratio, the higher level of insulin, of cholesterol, and mainly the higher situation in terms of body mass index. And this was not only different towards those with familial diabetes, but insulin below 12, but mainly in comparison to the patients with no familial diabetes. So the problem starts to be a little bit more clear, probably, but we have another issue. And the issue is if the response to the oral glucose tolerance test is very strong, very huge in terms of insulinemia, is this significantly, can be this significantly considered a signal of something impaired in these patients? So we again started from the group to disclose those who were hyperinsulinemic, so those who have a response of insulin to the glucose load above 50 microunits per milliliter, and from those who had no such kind of response. And we found that almost 85% of these patients were hyperinsulinemic in terms of response, with specific significant differences in terms of LH, ratio between LH and FSH, and mainly of insulinemia, which very high levels of insulin in comparison to the other group, also for some of the lipid profile. But look here, we have that those with hyperinsulinemic response have higher level of transaminase, which is something quite not expected, and it is paralleling what we have observed as in presence of familial diabetes. So we again tried to understand what was the behavior of the hepatic insulin extraction in presence or absence of the hyperinsulinemic response. And we saw that whenever we have a normal response to the glucose load of insulin, we still have the chance to see this decay, which was separating the fast release from the slow release of insulin, which is normal. But when we have the hyperinsulinemic response, which is for all these points significantly different from the normal response in these patients, we do not have this decay. And when we separate those with familial diabetes from those with no familial diabetes, we had the same panettone shape. And look here, a great amount, almost all the patients, 80%, 85% of the patients with familial diabetes were hyperinsulinemic. But look here, the patients with no familial diabetes, normal or hyperinsulinemic patients, well, they still have the presence of a shape completely different from here, and always showing the decay after the response at the 60 minutes of the test. So stating and demonstrating that the first phase release of insulin is absolutely distinguishable from the slow release. So things are going on quite smoothly here, since if we check again these patients according to the hyperinsulinemic or normoinsulinemic response, and in the same time showing and trying to see if we have the presence of familial diabetes or not, we found that in any case, the patients with familial diabetes, normal or hyperinsulinemic, always show higher level of transaminase in comparison to the patients with no familial diabetes. So this kind of observation clearly gives us ideas that the presence of diabetes is something which is driving some kind of impairment or ability to control, at least in these patients in the right way, the control of the insulin resistance and the insulin sensitivity. And when performing the combination also of the presence of the hyperinsulinemia with the familial diabetes, together with the levels of the baseline of insulin above or below 12, you see here that the presence of hyperinsulinemia and the presence of level of insulin above 12 is the most distorted curve, still with the shape of panettone, with no ability to disclose what is the fast and the slow release of insulin. The contrary in the patients with no familial diabetes. But look here, this is interesting. When we have no familial diabetes, but the presence of hyperinsulinemia, the patients, low number, that had high level of insulin in baseline conditions, that is above 12, they presented here the panettone shape, similarly to the patients with the familial diabetes. These are the most impaired patients, but those with a normal level of insulinemia, which is below 12, still had this very nice shape of the hepatic insulin extraction all along the oral glucose tolerance test. And when we checked the presence of the normal response to the oral glucose tolerance test in terms of insulin, we had that the very few of them that was located in this group were all having the very normal baseline levels of insulin. And this gives clear idea that probably the presence of familial diabetes is a sort of driving issue, driving factor to have much impaired situation in the control of the insulin resistance and obviously reducing insulin sensitivity. So just to give ideas, I know that this is quite complicated, so we have to go through these new issues quite carefully, but we can gain some clinical evidences. In PCOS, with the presence of familial diabetes and obviously PCOS, there is the condition of a much higher induction for high level of transaminase, and we have much higher occurrence of baseline level in the fasting morning of insulin, which is higher than 12. And this is important, the presence of familial diabetes is inductor of an abnormal hepatic insulin extraction under oral glucose tolerance test, because the panettone shape clearly demonstrates the lack of the distinguishment between the fast and the slow release of insulin. When we have no familial diabetes, we have clearly levels, normal levels of transaminase. 2/3 of these patients have the level of insulin in baseline conditions below 12. And the hepatic insulin extraction always show the transition after the peak, after the glucose load, and you can distinguish the fast release from the slow release. So what kind of conclusion we might say? That the first thing is that familial diabetes and PCOS predisposes to an impaired hepatocyte function. And this is probably clearly demonstrated by the fact that though within the normal range, the transaminase are at the upper limit of normality. The fact that the hepatic insulin extraction is dynamically behaving differently is something which is probably dependent from an abnormal way to clear insulin by the liver. And the transition from fast to slow insulin release is anomalous, but is not depending from the way of insulin to be secreted by the pancreas. It's always depending from liver function. And this is something that has been already thought and proposed, but not yet demonstrated in some patients, specifically in PCOS, by other authors in these last couple of years. So in PCOS patients with familial diabetes, impaired insulin degrading enzyme, which is the liver enzyme deputed to degrade insulin, is probably less expressed or less produced. And these create the combination with other diseases that are typically present in PCOS with familial diabetes that have been under discussion in this last year, such as the presence of the lack of epimerase, which is involved in the transformation of myo-inositol to dichiro, and also to the fact that the patients with PCOS and familial diabetes have also the reduction of the expression and the synthesis of the LASI, the lipoic acid synthase, which is responsible for another lack in the pathways controlling insulin sensitivity. So all these clearly say that when we have PCOS, we probably need to have a better, checking on the patients also from the anamnestic point of view. We have to give attention to the fact if there is in the family the presence in the fathers, mother, grandfather, grandmother of diabetes, because these create predisposition not only for the epimerase and LASI story and defect, but also to the IDE defect inside the liver. And we know very well that these might be disclosed by the fact that the transaminase is higher than the expected, though within the normal range. And the other problem is that the presence of insulinemia in baseline condition in the morning when fasting, if above 12, if you have the presence of diabetes in the family, is a sort of alert point that we might take in great consideration, since if combined to the other aspect that we have discussed, might give us the clear idea that we have a liver impairment which is probably responsible for the insulin resistance in these patients. And why we should have to take care of this? Because these patients might have the development of diabetes within 10 years, because these patients might have gestational diabetes if they become pregnant, because diabetes might occur after gestational diabetes in these patients within 5 years from the delivery. So these are patients that might have the right to be followed and, how do you say, treated, giving advices to take control of the diet, but also finding the integrative approach or maybe the treatment just to take everything under control. Thank you.
Thank you very much, Alessandro, for that beautiful paper that we have published. And Graham, thank you. And I will invite all our participants to send us their question. I think it's very important, this paper, because this underlines also the fact that the familial diabetes can have not only some impacts on insulin release, but also on liver insulin metabolism, and that probably also that liver function in these subjects could be touched by the diabetes in the family. Then we have a question from Sergio Brantes. I thank him for being with us. From Chile.
Hi there, Sergio.
Is any anthropometric characteristics, such as certain body mass index related to basal insulinemia greater than 12 microunit per milliliter? If so, why measure it in those cases?
Well, we have not yet created a sufficiently large database so that to cross together the anthropometric measurements and the insulin assay. But on my opinion, the body weight, probably the body mass index, is not really the most important issue, since the real problem is the consideration of how is the involvement of the biology in terms of insulin resistance. So this depends also probably in what kind of diabetes we have in the family, type 1 or type 2, and in the same time on how many subjects we have with diabetes in the family. Since we have observed, but not yet we have data just to discuss this more deeply, that whenever you have more than 2 patients in the family with diabetes, the aspects of the insulin resistance and the hepatic insulin extraction is much impaired than the others, even though showing diabetes. So there is a lot of items that we should have to consider. So the numbers should be not really 53 patients, but be probably 1,000, just to get more numbers and more appreciation of the insights.
And also more beautiful paper for Graham. And then we have a question from an anonymous: how this surprisingly novelty should suggest the clinician to behave with polycystic ovary?
This is the fundamental issue of this manuscript, since the real problem is that we need to have advices. The problem is not really what to give or to treat, is how to identify the patients for the right treatment. Since the problems are just the ability to see if the anamnestic investigation is good enough just to give clear ideas on how much the biology of that patient is predisposed to insulin resistance. Since the presence of diabetes is impairing not really the insulin degrading enzyme, we have already, but most of us have already demonstrated that the diabetes is affecting the expression of the epimerase. So we have the reduction of the sensitivity for insulin in the periphery, in the muscles, in the fat tissues, in our biology. And the second issue is that we have with diabetes the reduction of the LASI, so of the so-called escape pathway that creates control of the insulin sensitivity whenever inositols are not enough represented in the diet or produced in the biology. But if you lack LASI, epimerase, and IDE, well, we are in a bunch of trouble. These explain why we get better results in the controlling of the diet and the body mass index in patients with no familial diabetes than those with familial diabetes, since probably metformin is performing good for both groups, but better in those who have no diseases, let's say so, in the expression of enzymes. So it's rather important to understand the typology of patients that we have.
Then we have now, Alessandro, two questions. One from that I can link together, from Nihal Atipoglu and from Gabriela Ayala. Nihal Atipoglu asks, why do you think about the effect of metformin in this physiopathology? And Gabriela, with which point of insulin we need to treat patients with metformin? Do we need to put down our point of cut or base it in OMA index?
Well, the target is to reduce the insulin resistance. So the real problem for the use of metformin is that we need to know if the patients with PCOS, with insulin resistance that we have in front of us, has or not diabetes in the family. And I explain you why. The presence of diabetes creates the problem with epimerase mainly and for the LASI expression. We know very well that metformin is performing the action in the control of insulin activity and so improves insulin sensitivity since it works greatly inside the cells, accelerating the pathways where inositols are involved as a post-transcriptional signaling for insulin. So whenever we have someone with diabetes, probably the dosage of metformin that we have to use are higher than the other group of patients with no diabetes in the family. So the trick might be the combination of metformin with integrative compounds so that to improve the endogenous amount of lipoic acid or maybe of dichiroinositol or myoinositol, trying to find that integration of metformin with such complementary substances might give higher results in terms of rapidity to get better control of insulin sensitivity.
Thank you. And then another question, have we always to perform the oral glucose tolerance test, including C-peptide determination, to better evaluate the situation computing hepatic insulin X factor, or there are also any simpler solution?
Well, the study that we made was just to understand. So we made very complicated combinations of tables and graphs. But you know, Andrea, that I'm always complicated when I'm trying to understand something. But the real results here gives clearly the answer. We do not need probably to perform the oral glucose tolerance test, but we might just check the combination of specific issues. There is a sort of algorithm. You have diabetes in the family or not? What is the level of insulin in the morning, 12 or below 12? What is the level of transaminase, higher or not so much higher? And this gives you just the direction, since this means that you probably have an impairment in the control, if especially is related to the presence of diabetes. And the fact that we might perform an oral glucose tolerance test can give us mainly how much higher is the response of insulin to the glucose load. We really do not need to have, as we did, the assaying of the C-peptide all along the glucose load. But we might just have the assay of the C-peptide together with insulin in baseline conditions in the morning. Since if you have a high level of HEE, gives you clear idea that the degradation of insulin is not so efficient.
Thank you. And then now Susanna Aguilar, she asked, what will be the insulin cutoff point in adolescent with polycystic ovary syndrome?
Well, you know very well that adolescent people are not really similar to the fertile adult women. We have, in any case, to consider that adolescents still go on growing and changing the body mass in all terms, in the muscles, in the bones, and also in the fat tissue. But being the computation of the hepatic insulin extraction, something which reflects the dynamics of the clearance and together of the production of insulin, we might consider that from starting from adolescence up to menopause, this is a sort of index that might be easily and simply used. The real problem here is that we need to have the combination of all the issues that I told you. And in case for adolescents, it's important to know if they had any dependent in the terms of body weight and also of insulin resistance from specific epigenetic conditions, such as being born as GA or maybe UGR, or maybe they had the mother that during the pregnancy that they had with gestational diabetes, yes, because the epigenetics is still playing an incredible role in this.
Thank you. And then we have Fernando Barrera, who is asking, transaminases in this patient, why is important?
Well, transaminases are important since we have data from this paper and also from others that we have already published and we are now ongoing publishing, that the level of transaminases are reflecting a sort of sufferance for the hepatocyte function. And the data that we have, and we have recently evaluated also the administration of integrative compounds such as the simple lipoic acid, clearly demonstrated that the attack that we might do using antioxidant compounds improves the ability to function of the hepatocyte. And in a paper 2 years ago, we demonstrated that using lipoic acid, we reduce the level of transaminase. So this means clearly that we gain the ability to work for the hepatocyte if we reduce the reactive oxygen substances which are induced by the pro-inflammation, which is typical in the PCOS patients who also show intolerance to glucose, which is able to induce an incredible amount of oxidative stress due to the use of glucose. So there are clear ideas that probably the stress reactive oxygen substances are the really causal factor for this liver impairment, which if not cured, considered or prevented, might lead to the non-alcoholic fat liver diseases and to steatosis.
And then, Alessandro, what are the putative therapeutical approaches in case of this liver impairment?
Well, as I told you, we have data that are not yet consolidated because we are just gynecologists and we do not face the problem in terms of internistic aspect as a gastroenterologist, but we clearly have in our mind that the approach is with specific compounds who are able to reduce the oxidation inside these patients due to these metabolic conditions. So on one side, we should keep care for liver function, probably with lipoic acid or other substances who are really important, such the N-acetylcysteine or L-arginine, that are all able to give the so-called thiols radicals that reactivate the glutathione pathway, which is the most important, the most powerful antioxidant pathway that we have in our biology, which is greatly impaired in PCOS patients, especially in those with diabetes in the family.
And then you believe that also PCO patients, PCO should be considered also a disease where antioxidant, where the inflammation is generally involved in the subjects.
Absolutely, yes. You know very well, we are just going on in a very interesting study right in these weeks that we have the elevation, which is not, how to say, circumstantiated by the presence of sickness apart from PCOS. We have the elevation of all the interleukin, especially interleukin 6, which is the most important indicator of the pro-inflammatory states. And we have the data that EL6 is 2 times or 3 times higher in these patients than in the normal population, and is higher in PCOS patients with familial diabetes than in PCOS patients without familial diabetes.
No, then we have a question from Kariman Ghazal from Lebanon, who is asking the possibility to use in the same subjects a co-treatment where we can add metformin, inositol, vitamin D, and other substances.
Yes, this is an absolutely strategy. We should take the advantage of the combination of more than a treatment, because the combination is implementing the ability, since you are able to face specific different aspects that are at the base of the triggering of the insulin resistance. Since the most simple example is the combination of, let's say, metformin with dichiroinositol and lipoic acid. Because if you use dichiro, you implement, fortunately, the amount of dichiro inside the biology, which is reduced normally due to the epimerase defect. Similarly for lipoic acid, which is improved since giving lipoic acid, the LASI enzyme is not working properly. And this is working in the periphery. But lipoic acid is performing on the liver also. It's the most important antioxidant as protector of the liver function. And when you give metformin, you implement all the system that is acting, implementing the ability of insulin to reduce the glucose amount in the extracellular spaces. So since metformin is working using the inositol pathway, you need to have this in a good shape. So the combination has to be done thinking a little bit on what point we have to work just to improve the system and the metabolic pathways that are driving the control of not only insulin sensitivity, but the glucose control.
Yes, and I think on this point it's very important to mention what you have already spoken the last time that you were speaking with us on the fact that inositols are also involved in the second messenger also for TSH and for FSH. And I remind you that the FSH lack of stimulating effect in polycystic ovary is one part typical of the syndrome. Can you mention, can you make a comment about it?
Absolutely, yes. We have, I mean, when I talk with the colleagues on this, I always say that when God created the human being, he had not so much time to think to very different and complicated pathways just to drive so many different situations and conditions. He had probably one simple way of thinking. All proteic hormones need to have the same post receptor signaling.
Yes.
We change the receptor, not
Yes,
really
the receptor means the specificity.
Exactly. So the fact that when you drive the insulin sensitivity, taking care of the presence of inositols, you solve the problem of metabolism on one side. On the other one, you implement the sensitivity to the presence of FSH. And this has been clearly demonstrated by Artini from Pisa, that have performed a study just giving as complementary to the PCOS patients inositols, and they reduced, when inducing ovulation in these patients, of up to 50% the number of vials of FSH, just to get not only the same number of oocytes, but oocytes of higher quality and maturation. So this means that the signaling is important, incredibly important. So when taking care of the ability of PCOS to be able to reproduce, we have to think not really to the body weight, but to the pathways driving metabolism, because these are linked with the reproduction. Absolutely.
Then, now we are at the end, and I would like to ask you to give us a final comment, because you know the paper was strongly specific on that concept of the importance of the hepatic insulin extraction. And as a gynecologist, also even involved in gynecological endocrinology, I tell you, it was something really new, at least for me, but I think for most of us, the importance to evaluate the importance of the liver as organ responsible for the insulin extraction. And then while we have in the other side the huge clinical importance of polycystic ovary, and polycystic ovary with overweight and obesity, but also polycystic ovary without overweight and obesity. I would like that you can give us also a comment on this point.
Well, we have to think a little bit on one aspect. The presence of overweight or obesity is something which is occurring in these last 50 years. We had never been so obese as now in the previous centuries. Too much food, probably too much bad food, too much glucose, something that our biology was not really used to face. 1,000 years ago, probably there were no cakes, no sweets, nothing. So it was much easier to survive having vegetables and meat. Today we have vegetable meats and a bunch of other things. So our biology is really stressed by the metabolic pressure due to the kind of food which is something to which the biology is not really used. So the first thing that we need to have is the attention on how the metabolic pathways are involved, so that to face the kind of nutrients that we have. So the second issue is that PCOS nowadays is characterized by the overweight or obese PCOS, but also the normal weight PCOS. Do not believe that the normal weight PCOS is different from the overweight or obese, because those who are with normal weight, with PCOS, maybe oligomenorrhea, hyperandrogenism, probably might be, not all, but might be people that are taking care with physical activity, attention to the food, to the body weight, and obviously to the kind of nutrients. But if they are coming from a family with diabetes, they have in pectore the hyperinsulinemic conditions just waiting to jump out as soon as they have a pizza or maybe a cake or whatever. Or they probably might one day stop running or jogging. So they might gain body weight. So we have always, and this is something that has been stated by the American Society for Reproductive Medicine in 2007, they have stated that no way all PCOS need to be studied attentively also with the oral glucose test, having glucose and insulin assayed in the same test, since This is the only way to be sure for the presence of the hyper response and also for high level of insulin in baseline condition.
We have now Andrei Ribanov, is one of our followers, who have made an interesting question. In your opinion, what other agents may be used in insulin-resistant in polycystic ovary patients? Thiazolidinedone, such as rosiglitazone and pioglitazone, glucagon-like peptide 1 receptor agonists, such as sitagliptin, can they be used in monotherapy or in combination with metformin?
Well, not easy, since for me, I am endocrinologist, but I am devoted to gynecologist. But I can tell you something, that we do not have right now all the answers to the questions that we might have in our mind when facing insulin resistance. We need to know if there is any change in the receptors that are for insulin, since we have right now disclosed all the impairments in the post-receptor signaling. But I am sure that probably there might be some kind of changes also in the receptor structure. So the use of specific other substances, such as those acting on the receptor, might be a good choice, maybe in combination with complementary treatments, since the post-receptor signaling has always to be considered.
Okay, thank you, Alessandro. Thank you very much. Then, as we normally finish, do you have any special comment that you want to close your presentation?
Well, the comment that I can give is this one, is something that I always say to my postdoc doctors that are working with me. We need to be first general doctors, general practitioners. Please, let's visit the patient, then we have and we need to start to be specialists for gynecologists and obstetrics, since we need to have clear idea of the global state and the anamnestic conditions of the patients before being the gynecologist.
Thank you very much. And I thank not only you for the presence, but the beautiful paper that you have published on GRAM. And I would like to invite all people participating in our session to submit their articles. I remind you that up to now, the ISG Society have decided to publish for free. Once that the article has been accepted, it will be published for free on GRAM. It's a great opportunity. It's an open access journal without charge at this moment. And then with this in mind, we will have soon the next issue. They will appear next issue. And in the next issue, we will select papers such this one from Alessandro Genazzani, who will attract our participants. Alessandro, we are still over 160 following the lecture. And then thanks to all of you. Enjoy, have a good summer, and we will meet again in September.